So we're going to talk a little bit about next steps in the dyad kickoff and so forth. Our timeline, as we're now moving forward on these dyads, is today's the launch. So the rocket is taking off right now, probably shaking a little bit, but we don't think it's going to explode. We want to get to the moon, and we're hoping to get there. So hopefully you've been able to pilot this now. We'll have weekly huddles that you all will start undertaking. You'll be talking to your sponsor. Hopefully within the month, they'll be reaching out to you, or you reach out to them even sooner. And then we're going to be planning for our first PDSA sprint, a small effort where you can focus on change on your units or procedural areas and so forth. And then we'll be sharing your successes and talking about it at our November Quality Collaborative meeting. This will be to, if we'll monitor how things are. The goal is to finish this PDSA sprint by the end of the year. You'll continue your weekly huddles, meeting monthly with your sponsors, and celebrate success. And when you have good stories, we want to hear about them and share them so that mainly people can learn about it and demonstrate the successes that are occurring. And again, so this monthly collaborative and quality will be undertaking, probably integrating it with the monthly quality report, and then I'm going to talk about these other supporting infrastructures. So your tasks, continue the weekly huddles, meet with your sponsors, put this on your calendar, November 27th, quality collaborative meeting from 4 to 5:30 in MM363. Focus on peer learning. This actually even came up in our dyad as I threw out one of the curveballs. Yes, we are going to change things, and so we really want to learn how you've done this, and then we'll have your PDSA plan improvement sprint completed by December 31st. And I am sure there will be some wildly successful stories, and then we're going to have some that may be not so good. But I can tell you one thing. When I've succeeded, I went, oh boy, and kept plowing ahead and often forgot that. When I've made a mistake, notice, this was a real big life lesson when you make mistakes. You don't forget those. So a lot of people are wondering, well, what is a PDSA sprint? And this is basically taking what you learned in your training, the focus, identifying the problem, organizing your team, clarifying, understanding, and then specifying what is going to be your intervention. And now you link it to a SMART goal, and then do the plan, do, study, act. And Audrey and Jing and Barb, I got that right, correct? See, this is how we developed our Center for Health Services Research. I told them, you tell me when I'm wrong, and we'll succeed. This is really good opportunity to sequentially build knowledge for your entire team around not only what are the issues, but how you can address them successfully. And then you'll do things on, if you will, minor scale initially, and then steadily scale it up. I suspect we're going to find that some units will discover something that's been happening regularly for years, something we learned from Cincinnati that I think is very helpful. As soon as you hear one of your team members say, oh, we always do that, that's a good alarm bell of that's something probably we need to work on. So these PDSA sprints force us to think small, be methodical, make predictions and see if they turn around, and then you get rapid adaptation and implementation in our busy healthcare settings, because we still got to be taking care of patients, no doubt about it. This is from Cincinnati Children's. Interestingly, I remember putting a diagram just like this in a grant proposal way back in the late 1990s, that you take best evidence, you test it on a small scale, you follow up, and you keep doing these multiple PDSA cycles of change to get to the point where you then can have wide scale and get change that results in improvement. Doesn't this just look beautiful? It is simple. Well, this is what PDSAs are really like. I love this article, and I'll send it around. Greg O'Grink published this because this isn't what happens. As you do a PDSA, it goes off track, you have to go backwards, and it's up and down. But if you keep going with time and you keep addressing the challenges, you still can end up there. Just recognize it isn't going to be always a simple, smooth process as we do this. But, and what you're going to find as you do this, and as the staff see that we try, it didn't work, but we kept trying and we eventually succeed, you're going to go from prototype to pilots to adapt and spread, and there's going to be growing belief that, yes, we can change things. So the curveball that I threw out when I was facilitating my table, and I enjoyed seeing my colleagues look and go, oh, there goes Mark again. This isn't part of the plan. Thank you. You know, I said, nothing ever changes around here. Well, I think you all are in this room because things are going to change now, and that's what we're trying to do. And we have a lot of help. We have a lot of tools. They're on the web. You've got them in your binder, and we're going to send out more. As Mark Newman said, we're going to communicate. We have coaches. You can email to contact them at value@uky.edu. You need data, send it there, but we're going to come up with another simple website. And if you can remember 4 letters, DASC, dask@uky.edu. That's our data analytics and statistical core in our Center for Health Services Research. That is where we house our about 18 data analysts, statisticians, et cetera, who can provide you help with obtaining data, and we're here to help you. So dask@uky.edu for data, value@uky.edu to access the Ovid team to help you. And call your sponsor. They can also connect and help you get subject matter expertise, and we'll go over those sources too here shortly. And then we're going to be having these quality collaboratives to share information. And so Office of Value in Healthcare Delivery, Jingli and Audrey Yates, you can get them at value@uky.edu. Quality monitoring and reporting, patient safety and so forth. Email Amanda Green or Stephanie Durbin. Amanda's email's up here. Office of Patient Experience, Angie Lang, and I'm sure Paula Bailey will be also glad to help you. Email them directly, and they can provide you the subject matter expertise. So a lot of support as we undertake this initiative, and I think that's going to be critical to our success. There's no wrong door for any question. If you're getting frustrated, email me, and we'll get things taken care of. So believe it or not, we are doing a lot of this. And remarkably, I got an email this week from a patient. And what it demonstrated to me is, A, we are delivering patient-centered care. And what it also demonstrated to me is how some structure and process we'd already been putting into place was having an impact. It was changing outcomes. I want to thank Colleen, and wherever you got that from. I love that idea. No outcomes, no income. You know, because that's what value-based care is. So this Wednesday, October 24th, good evening, sir. I didn't email her back and say, please call me Mark. I am writing this email in regard to good care provided by Dr. Pradeep Yara, who has taken care of me during my recent stay at Good Samaritan Hospital. I was admitted last week for medical problems. I want to appreciate Dr. Yara for the concern he showed as a physician and excellent quality of care provided to me. He was kind, caring, and came out as a physician listening to my concerns. Dr. Yara spent enough time in making me and my husband understand my condition and explaining to me the need for follow-up. Dr. Yara also acted as a good role model for the medical residents by sitting bedside, explaining care, and importantly, the human side to his treatment. He also addressed my concerns at discharge regarding home care by communicating with other specialties. Thank you. Well, the thing that struck me about this is it was efforts we'd undertaken with implementation of ITEM at this hospital, what was a model unit basically on Good Samaritan 7. Sir, you know some of these. And one of the things we realized is that there's a huge amount of literature on sitting down when you talk to patients. Patients love it. They think you've spent double the time you would have if you were standing up. And so you're going to be encountering some problems, and I want to give you this example for this. There are gremlins out there that will try to thwart you, and you will never guess where they'll come from. So Preetham Talari, who was at the time the medical director for 7, really drove this. He brought this up. He heard me talk about this. There was a publication in the Journal of Hospital Medicine, and so we wanted to follow this evidence-based care. And so we got some stools. It took a little while, but we were persistent, and we got stools to put in all the rooms. And the clinicians were educated to why it was important to sit down when we talk to patients. So we thought, this is going to be great. We'll implement this evidence, and it'll improve things. It didn't work. And it was kind of interesting what happened to those stools. Here's an example. So people used them for all sorts of things. They actually became a nice place for patients to put their things and pile them up. and we couldn't use them. Preetham didn't give up. He worked with the nursing staff, and we put labels on them. We probably need to change the labels. I think at this point we need to say team members only, as we're working together as a team. And what happened is that now they're being used, and now we're getting letters where patients are thanking us for taking the time to sit down and talk with them. And so this is where I think we can head with this, which is just incredibly exciting.